When does a sensational story about a virus start to get in the way of treating patients? In this piece from 26 June 2026, an infectious disease doctor examines the complicated influence of Richard Preston's The Hot Zone. That bestseller drew a generation of scientists toward the front lines of epidemiology, yet it also left behind a sensationalized image of Ebola that still skews public perception. This account considers how a single book's storytelling choices can inadvertently shape global health policy for decades. It directs attention toward the human struggles and fragile health systems that dramatic narratives often bury under a sense of biological terror. Written by Krutika Kupali in Stat News, narrated for Alva.
When news breaks of an Ebola case almost anywhere in the world, the public reaction is remarkably predictable. Headlines become urgent. Social media fills with anxiety. Questions arise about whether this is the beginning of another global crisis. More than 30 years after its publication, much of that reaction can be traced to a single book. Richard Preston's The Hot Zone captivated millions of readers and introduced the public to a virus that most had never heard of. It also inspired many people to pursue careers in infectious diseases, including me. I first read it in college. Like countless others, I was fascinated by the intersection of medicine, epidemiology, and emerging pathogens that the book portrayed. Although my understanding of Ebola has changed profoundly over the years, I still recognize the important role the Hot Zone played in drawing a generation of physicians, scientists, and public health professionals into this field. At the same time, the book left behind an image of Ebola that continues to shape public perception today. It is an image of an unstoppable virus that spreads effortlessly, kills nearly everyone it infects, and threatens anyone who comes near it. It is compelling storytelling, but also an incomplete picture. I have spent much of my career working on Ebola, caring for patients during the West Africa epidemic, helping establish Ebola treatment units, conducting clinical research, and working on Ebola preparedness and response planning. Those experiences taught me that the reality of Ebola is simultaneously less sensational and far more challenging than most people imagine. People often ask what it is like to work during an Ebola outbreak. Many expect stories filled with constant danger and chaos.
The truth is that much of the work is remarkably human. Some days are spent inside an Ebola treatment unit, caring for patients who are frightened, isolated, and desperately ill. Clinical care often begins with simple interventions that can make an enormous difference. It may mean staying by the patient and encouraging them to drink oral rehydration solution despite unbearable nausea and diarrhea, because every sip helps replace the fluids they are losing. It means carefully monitoring for dehydration, replacing electrolytes, managing pain and fever, treating secondary bacterial infections when appropriate, administering intravenous fluids, and providing other supportive therapies when resources allow. Every decision must be made while wearing layers of personal protective equipment in extreme heat, working against the clock before the time inside the red zone comes to an end. Equally important is remembering that every patient is a person. Some worry about their children, spouses, siblings, and parents. Others wonder if they will survive or whether they will ever see their families again. Most are completely alone because visitors cannot safely enter the treatment unit. Providing compassionate care often means offering reassurance or simply being present when someone has no one else. Outside the treatment unit, the work continues in ways that rarely make headlines. Days are spent strengthening infection prevention and control, improving laboratory capacity, training healthcare workers, tracing contacts, meeting with community leaders, supporting safe and dignified burials, and working alongside ministries of health and international partners. Successful outbreak response depends on thousands of small decisions made day after day.
None of this resembles the image of Ebola that many people carry in their minds. Popular portrayals, particularly The Hot Zone, helped establish a lasting image of Ebola as a uniformly hemorrhagic disease in which patients bleed from every orifice and suffer catastrophic tissue destruction. This portrayal does not reflect the clinical reality for most patients. Overt bleeding is neither universal nor the defining feature of Ebola virus disease. Most patients present with fever,
profound fatigue, vomiting, diarrhea, and abdominal pain, while severe illness is driven by dehydration, shock, immune dysregulation, and multi-organ dysfunction, rather than catastrophic hemorrhage. The persistence of these misconceptions matters because clinicians and the public alike may expect Ebola to look dramatic from the outset, when in reality, its early manifestations often resemble many other common infectious diseases. Another persistent misconception is that Ebola spreads easily among the general public. Decades of scientific evidence tell us otherwise. Ebola is transmitted through direct contact with the blood or bodily fluids of someone who is symptomatic or through contaminated materials. Casual contact, sharing public spaces, or walking past someone in an airport does not place people at meaningful risk. That distinction matters because perception often shapes public behavior more than science. Whenever an imported Ebola case is identified in Europe or North America, it becomes international news within hours. At the same time, hundreds of patients, healthcare workers, and families in affected African communities may be confronting the outbreak with far less public attention. Anxiety about Ebola is understandable.
It is a severe disease with a high case fatality rate, and every case deserves attention. However, fear fueled by misconceptions can distort public health priorities. It can encourage policies like travel restriction that appear reassuring while contributing little to outbreak control, and it can distract from the interventions that actually save lives. The greatest obstacles to controlling Ebola are rarely the virus itself. Conflict that prevents responders from reaching communities, fragile health systems, shortages of laboratory supplies, under-resourced healthcare facilities, misinformation, community trust, population displacement, and declining global health funding present far greater challenges than the biology of the virus. Encouragingly, the story of Ebola has changed dramatically over the past decade. During the West Africa epidemic from 2013 to 2016, we had no licensed vaccines and no proven therapeutics. Today, we have highly effective vaccines against Zaire Ebola virus, monoclonal antibody therapies that improve survival, rapid diagnostics, stronger infection prevention and control practices, and a much deeper understanding of how to care for patients. Those advances deserve far more attention than they receive. The ongoing Bundibugyo Ebola virus outbreak in the Democratic Republic of the Congo reminds us that important gaps remain. We still lack licensed vaccines and therapeutics for every Ebola species, and humanitarian crises continue to complicate response efforts. These realities underscore the need for continued investment in preparedness, community engagement, research, and health systems, rather than fear-driven reactions whenever Ebola appears in the headlines. Risk communication is itself a public health intervention.
When communication emphasizes fear over facts, it can unintentionally amplify anxiety and undermine trust. When it accurately explains how Ebola spreads, what actually places people at risk, and how outbreaks are controlled, it empowers communities to respond rationally rather than react emotionally. The Hot Zone deserves credit for introducing many of us to the world of emerging infectious diseases. It sparked curiosity, inspired careers, and reminded readers that pathogens emerging in one corner of the world can have global consequences. 30 years later, however, our understanding of Ebola has evolved enormously, and so should our public narrative. The real story of Ebola is not one of inevitable catastrophe. It is the story of patients fighting to survive, healthcare workers delivering compassionate care under extraordinary circumstances, communities rebuilding trust, and scientists and public health professionals working together to stop outbreaks. That story may be less dramatic than the one that first captured the world's imagination, but it is far closer to the truth. Krutika Kupali, MD, is an infectious diseases physician and former World Health Organization medical officer. She served as medical director of an Ebola treatment unit in Sierra Leone during the 2013-2016 West Africa Ebola epidemic and has supported Ebola preparedness and response efforts in Africa and globally.